Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland. And welcome to this, the second in our 2016 QI Connect Global WebEx series, and the 20th, in fact, since we started the series. This idea came from a request from our national clinical leads here at Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And we've had very many new organisations and professionals joining us since the clinical leads came up with that idea a couple of years ago. And you'll hear more about them just in a moment. However, let me just introduce you to Jennifer Graham. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon, everyone. Welcome to the session. I'm just going to take you through a couple of housekeeping slides with regard to how to use WebEx. We want today to be a really fun and interactive session. So if you could please use the chat box to ask any questions and get involved in the discussion. And I'll go on to tell you a little bit more about how to use the chat box. If you are having any technical difficulties, if you could message the BT call manager via the WebEx chat function or by pressing *0 on your telephone keypad. So how to use chat. So if you'd like to get involved in the conversation, which I hope you'll do, if you could click on the chat icon, which is at the top right-hand side of your screen. It looks like a speech bubble. It's just circled here in red. And you should see a list of everyone who's on the session. At the bottom of that screen, you'll be able to just type in your message. And if you click select send to all participants, that means we can all see the chat throughout the session. So, as I say, we want this to be a really interactive session. We've got lots of friends joining us from all around the world. So, we just want to try and see where you're all joining us from. So, if you could just click on the icon, which looks like a pen there, it's circled in red. And then just click on the arrow. Okay, 3, 2, 1. So if you could just show us where you're linking in from. Welcome to everyone. Welcome to Ross from...
Well, Ross looks as though he's in the west coast of America, but Ross is from Toronto.
All right.
So he's obviously visiting in the west coast. Or his geography is a bit off, but I'm delighted to see all the attendees from all over the UK and many other countries also. Great. Jennifer, we're going to go on and just say a little bit more about the series itself. We're absolutely delighted now that QI Connect is reaching out to more than 360 organisations, increasing our reach with every single episode of the series. So we're just going to take you to a bit of a competition. Now, those of you that have been with us for a while will recognise that we've got a little bit of a competition. So again, we're just trying to use those arrows on the left of the screen. And if you just go onto the arrows, you'll see that these are the countries that are now joining QI Connect, either live or recorded. We have more than 45 countries. And today I'm going to name a country, and when I name that country, the first person to get their arrow on the country's flag will win a wonderful prize that I'll tell you about just in a moment. So here's the country. Fingers at the ready. The country is Canada. Oh, Caroline Stephen. Well done, Caroline. That was exceptionally quick. Well done. So thank you, proving that people are using the WebEx and using the functionality. Thank you very much, and a big shout out to Canada for joining us today. And the winner, Caroline, will receive a signed copy of Charles Vincent and Renee Amalberti's new book, Safer Healthcare. This book was just published in hard copy last week. However, we're also just about to tweet the link to the free soft version available online from the Health Foundation. A wonderful description of safer healthcare strategies for the real world, signed copy from Charles Vincent. So well done, Caroline. Now, when we started this series, we had one slide showing the organisations that joined the organisation, joined QI Connect. We now have 12 slides covering organisations from all over the world, from those 45 different countries. And we're absolutely delighted to have such a wide reach for the organisation, for QI Connect. And we're always delighted to give a shout out for our university friends. And we're now reaching 33 universities with a list of new organisations, St Andrews University and the University of Toronto joining us for the first time in today's episode. We also are delighted to see the extension beyond healthcare into social care, into local authority, and delighted that my hometown of Glasgow City Council are signing in today, and also colleagues from the Isle of Man, Yongshapin, and elsewhere. So welcome to all our new participants to QI Connect. We're absolutely delighted that you could join us. And as we've highlighted, we record all the sessions of QI Connect so that they can be watched at your leisure. And indeed, we've now got quite an extensive back catalogue on our website. And Jennifer will just link type in the link to that shortly. So this is the website. We've got all our resources from all of our previous episodes here, freely available, and we're delighted that it can be used again and again. We're also delighted to continue our relationship with ISQA, the International Society for Quality in Healthcare, and their use of the QI Connect series as part of the resources for their fellowship program, which we understand is a global venture, and delighted to be partnering with them. We thought we'd call out a usual call out to the small but perfectly formed QI Connect team. You've heard from Jennifer, and joining us today in the studio is Olivia McDougall, who's running with all of the administration and also helping with all of your certification after the seminar. We're also delighted, and you'll hear a bit later in the call from Akin Akinola, who's a specialty doctor for quality improvement in surgery at the Golden Jubilee National Hospital, which is part of the Golden Jubilee Foundation here in the west of Scotland. Akin is also the instigator of the Improvement Club, which comes together once a month there and studies quality improvement. We're delighted to have Akin joining us as the first questioner when we get to that section of our talk later today. However, I am absolutely, before I get to the speaker, let me just remind you to tweet. We're at hashtag HISQIConnect, and you can follow us at HISQIConnect also. I am, however, absolutely delighted to introduce our speaker today, who is Joe Bibby, the Director of Strategy and Innovation at the Health Foundation. Joe started with the Health Foundation almost 10 years ago in 2007 and led in the development of the Foundation's influential portfolio on patient safety and person-centred care, and has had previous roles at the Department of Health and the NHS Modernisation Agency, where she led on the development of the International Quality Improvement Initiative Pursuing Perfection. Joe was appointed a non-executive director of Salford Royal NHS Foundation Trust with a special remit for innovation and improvement science, and she's also an independent member of the National Information Board. So we're absolutely delighted to welcome Joe to the call today. Good afternoon, Joe.
Good afternoon, Brian, and hello everyone else listening.
Now, Joe, I've just passed the ball to you, so we look forward to your talk, and we'll speak again soon.
Okay, great. Well, thanks very much, Brian. Brian's told you about my background, so I don't need to say anything else on that. But just to talk a little bit about my role here at the Health Foundation now. In the last year, I've taken the role of Director of Strategy and Innovation and have a responsibility for some of the strategic development of the Health Foundation. And there's sort of two elements to that. One part of it is that I'm scoping a program of work we're doing around improving health, so not simply looking at improving healthcare, but how do we improve health, population health. And then the other role I have is a kind of watching brief on innovation that's happening across healthcare sectors in this country, wider, and also innovation and how it's being approached in other sectors. And I've really had, this great opportunity over the last year to go to some really fascinating meetings, conferences, chance to read, sort of just dig around, find out what's going on out there. And what I'm hoping to share with you over the next 30 minutes is, I suppose for me, some of the sort of highlights, take-home messages that have come from this last year, and hope that it will provide people with some pointers to resources and ideas that they can find useful. But I was just going to spend a couple of minutes talking about the Health Foundation for anyone who isn't aware of our work. We're an independent charity. We work across the UK. We have an endowment which allows us to fund research, improvement work, policy analysis. We have in-house teams that do economic analysis and data analysis. Our strategy, our mission is that we want better health and healthcare for people in the UK. To achieve that, we think it's necessary, firstly, to improve health service delivery, secondly, to improve the way policy is made, and then thirdly, the area that I've been working on as well, to improve health. And we have a range of strategies for doing that, testing innovations and spreading what works, building skills and knowledge through fellowships, and developing and sharing the evidence base through work that we commission and work we do in-house. So a broad and exciting remit, and as Brian said, over the past sort of 10 years, we've had a particular focus on patient safety, and so we have resource centres on our website that you can go to that convey a lot of the learning that we've gathered over the past 10 years. So we have a resource centre on patient safety, on person-centred care, and we also have, dozens of publications, it has to be said, 3 recent ones that I would hope would be of interest to the audience. Today we've recently published a piece of work we've been doing jointly with Nesta on kind of realising the value of community-based assets and people in supporting healthcare. We've recently published a study looking at the habits of an improver, so the knowledge base around improvement and the skills that people need. And also a recent publication was the continuous improvement of patient safety, which really tries to draw together the body of learning over the last 10 years at the Health Foundation. So a lot of things on our website if you go there and have a look, and some places you can find out more. But moving on then to the topic of innovation, which, as I say, I've had the chance to be thinking about over the last 12 months or so in some depth. And I think clearly innovation is, sort of word of the moment. People use it very widely. It's just one of those things you come across all the time. But what struck me as I started trying to make sense of the innovation space was that the way innovation is being used as a term is, I think, sometimes quite confused and quite confusing. And when I thought about this, what struck me was that actually sometimes when people were talking about innovation, they were talking about it as a noun, an innovation. Sometimes they were talking about it as a verb, to innovate. And sometimes when they were talking about innovation, they were talking about being an innovative organisation or an innovative person, so as an adjective. And I know, there's a risk this sounds a little bit sort of pointy-heady, but it just struck me that actually, depending on whether you're talking about it as a noun, a verb, or an adjective, actually, it's a different body of knowledge you need to draw into, tap into. It's a different set of ideas you need to connect with. And so what I thought I've been finding as a useful way of just processing my thinking is to make this distinction. And so this is how I'm going to structure the talk this afternoon. So first of all, talking about innovation as a noun. And so, we're familiar with this. It's a new method. It's a new idea or product. It's a thing. And I suppose one of the things that has struck me, and this is particularly in the past sort of 5 years at the Health Foundation, I was responsible for our innovation program, Shine, and setting up our new innovation program. And one of the things that really struck me is that innovation is it's in the eye of the beholder, because the fact is if something's new to you, it's new, it's an innovation, and we all, everybody's probably familiar with the diffusion curve and the early adopters and the laggards and so on, but innovation is something that's new to you, and also the value of it is often a kind of very subjective value. So just as an illustration, my favourite innovation at the moment is one I've come up with myself, which is I shrunk a cardigan, and it was a really nice cashmere cardigan, and what I realised was that rather than throwing it away, if I chopped the sleeves off, I got both a really nice pair of gloves and this little jacket. And since I've got quite a lot of shrunk cardigans in my drawer, I'm quite excited about that innovation. But obviously that is not necessarily an innovation that's going to be useful to anyone else or even desirable. So what I wanted to go on to talk about is where can we look for innovations? What's out there? What are the resources that we can tap into? And over the past year, I've come across some really great things that I think are really valuable. So first one, actually, in some ways, not dissimilar to QI Connect, is the Innovation Learning Network, which is brings together about 60 different organisations globally. The NHS, I'm not sure about Scotland, but I know the NHS in England is a member of this. So in fact, anyone with an NHS web email address can sign up as a member, and they run virtual sessions every fortnight on different topics of innovations around improving quality delivery of healthcare. They also have a strong theme around use of technology at the moment, which is interesting. And they have 2 annual meetings, in-person meetings, and they also do run some collaboratives. So they've got a lot of interesting materials, back catalogue as QI Connect does on their website. Another source of innovations that I've come across is the Maths Challenge, the UK Maths Challenge. So this is something that was started in Boston, and it was a kind of a prize award for people with innovative ideas, and people send in their ideas, and if selected, they're given the space and the support and networks to develop their innovation to take it to market. And in Wapping Tobacco Dock in London is where the UK Maths Challenge is based, and they have about over 100 innovators there at the moment. And about 20 of those are working on innovations in healthcare. So if you again, go to their website, there's little profiles of all the innovations that are there. And they open again to invite ideas, innovators to apply later this year. Sort of similar in intent, in the sense of the idea of an innovation accelerator. Health Foundation has been working with NHS England and UCL partners on supporting about 16 innovators to, again, sort of develop and accelerate the spread of their innovations, and you can find more about that on the NHS England website. So they're all examples of kind of where we can go and look for very specific ideas, concrete ideas of innovations. The other thing that I've kind of come across, obviously, is this, sort of different types of innovation. So, we're all familiar with the kind of technical innovation that, we all live with and consume as fast as we can. But the other area of innovation that people have been talking about probably the last 5 years or so is the concept of frugal innovation. So innovation which is about reducing the complexity and cost of a good and its production, usually to kind of open it up to markets that have fewer resources and therefore need a lower cost product and are able to consume that. And 2 years ago, I was a lot of the frugal innovation that people talk about comes from, particularly in healthcare, examples in India. And I was lucky, I did a study visit a couple of years ago to India and saw some of these hospitals that were delivering outcomes that were world-class outcomes, but at a fraction of the cost in terms of delivery. And two examples here, both in fact eye hospitals, but it's not restricted to that sector, the LV Pressured Eye Institute and Aravind. And I think what was really interesting about seeing these innovative organisations that are delivering high quality at low cost was the things that were common to them was standardisation, so a drive for standardisation that was just so deeply embedded in the culture of the organisations and deeply embedded in the kind of clinical body and the management body. And so driven by standardisation, driven by the need to constantly look at how do we increase volume throughput as a way of reducing costs, and also looking into how can we tap into wider assets besides outside of the healthcare delivery system. So, for instance, the LV Pressured Institute, they offer eye care, and they have these several layers that they display in this pyramid. So at the top, they have Centre of Excellence hospital in Hyderabad that is doing, world-class transplants, grafts, stem cell research and transplants and so on. But what they realised was, it wasn't good enough, obviously, just to be intervening there. They needed to have levels of care for all the different levels of need, and they have this tiered structure. And the lower one that I wanted to point out, the Vision Guardians, was really interesting because the concept of Vision Guardian was just about giving somebody in a community enough knowledge to spot if somebody had eye problems. So they could be a primary school teacher, they could be somebody delivering the post, they could be somebody running a small shop. But they had this recognition that if they were really going to be able to identify the need out there, they needed to skill up just the lay population. So I think what I felt after having seen these examples was that it was deeply impressive, but the context was so different that you could see, well, yes, lots of people write about Aravind and so on, but we've never quite replicated it. But actually, I think there is something about this question of how can we deliver services at a lower cost and really think about that in our context. The sort of next type of innovation that I think people are talking about a lot now, and I think this one probably really resonates with healthcare, is social innovation. So a novel solution to a social problem, which is not just more effective and efficient, but it's sustainable and just. So these social values, and also that the value created accrues primarily to society. So it's not, the kind of profit motivation. It needs obviously to have a business model. And some of the examples that people will be familiar with and may not have thought of them in these terms, but the Fair Trade logo and accrediting is a way of marking out goods that are delivered in a way that's fair and equitable to the workforce, and so that's driven changes in the supply chain. Dementia Friends is an example of a social innovation to support people with dementia. Wikipedia is something along those lines. My favourite one that I came across is something called Casserole Club that operates across the UK, which was actually set up by a guy who was a performance manager in a local authority somewhere, and he was really struck, reduce cost being cut, services not very good in terms of getting meals to older and vulnerable people. And he had this idea of what if he could just connect people who liked to cook with people who needed meals, like who just lived down the road or next door. And so he came up with this idea of Casserole Club, and they cover, quite a significant part of the country now where they connect people up to, people can make the meals and then they take them around to people who they've been matched up with. And I think, it's a great idea of the example of a social innovation, because it's not only delivering the value to the person receiving it, but the person who makes the meal is doing something they enjoy and getting that sense of being part of community. So the other sort of slightly more theoretical thing that I've come across that I think is really useful when we're thinking about healthcare is something called Doblin's 10 Types of Innovation, and there's quite an extensive website that you can go on and find out about this. But looking at this, what really struck me is that in healthcare we often think about innovation quite narrowly in terms of what Doblin would call the offering. But Doblin's 10 Types of Innovation look at 3 areas. The first is configuration, so how is the business configured? And the first one here is profit model, so looking at kind of in a sense, how can you sell something that somebody didn't know they wanted, I suppose. I mean, so I heard recently that apparently Canada is starting to sell air to parts of, I think probably China, some of the industrialized parts of China, because their air quality is so low. So there's a profit model innovation. They found something they can sell that they didn't know they could sell. And in some ways you could say, well, this isn't particularly relevant to the NHS, but I think it's interesting, there's a big move to workplace wellness. And so, you know, big employers are starting to look at providing services to their employees, and where does the NHS have a role there is something to think about. Second configuration innovation is the use of networks. So how do you connect how do you create networks around your offering to sort of add value? And so I think an example of where you see this is in big shopping centres, where the shopping centres are put up and the food restaurants get these discounted rent on the properties, because they know there's this symbiosis thing that we like to go and shop and we like to eat at the same time and watch a film. So how do you create this network that pulls everybody in and then helps everybody's business? But again, in healthcare, I do think when we start to think about this, there's opportunities. As Brian said, I'm a non-executive at Salford, and one of the things that we've had there is, CAB, Citizens Advice Bureau, sort of go in and help patients who have been admitted and maybe, need some help when they're being discharged because they're needing to access benefits they're not familiar with. And when the hospital was reconfigured, the CAB office got moved somewhere off, sort of not so convenient, and they kind of said, well, this is really inconvenient for us now to get to talk to patients. And actually, there was a recognised value of the CAB being closer. So that's a kind of example, I think, of where building the networks and the people in your network who are providing other services that are compatible. Structure, so a lot of this around innovations in the way back offices are delivered, but I think also interesting things around talent management. Could we be doing more talent management around the healthcare system? Do we need to think about how we innovate there in order to develop and grow our workforce? Process innovation. So what this tends to be about, things about the way you do your business. So an example might be, I guess, we take it for granted now, but when ticketing prices were brought in that varied depending on the time, so whether you go to the cinema, it costs more on a Saturday night than it does on a Thursday afternoon. Whether you're travelling on the train, it costs more before 9, So that was an innovation about the process of how the business was delivered. And, should we be thinking about how we need to innovate in the way we deliver healthcare? We know, for instance, that a lot of the problems we see at A&E in the evenings are because of the disconnect between when GPs will be referring patients on from their evening clinics and then the day staff in A&E signing off. So there's I think that's an example of where we need to innovate around our processes. The second area, which is I think where we tend to think about innovation in the health system, is around our offering. So the product performance would be about finding a product that has that kind of competitive edge in terms of being able to deliver the outcome in a novel or better way. And I think we see that a lot, but in fact what Doblin says is that improved product performance tends to be where there's the least headroom, because as soon as you get a competitive advantage with your product, everybody else starts to replicate that. The other area is the product system, so thinking about how can you how can you have complementary products that, again, sort of reinforce each other. So I suppose it's a bit like, if you book a flight now, you can book your car hire, you can book your hotel. But, I mean, it's a bit like the way we've innovated with one-stop shops in healthcare, so one-stop clinics for, getting all the diagnostic tests done together, or the way in which the fire service, for instance, in parts of the country are now doing health checks and doing things that just to sort of check it when they're doing a house check on fire safety, that they are being trained to do some sort of basic health checking as well. So I think, again, how can we think about the way in which we can connect with other products? And then the third area of Doblin's 10 types of innovation is around the experience, and how do you innovate around the experience that people have. So the service experience, is the sort of stuff that we would be familiar with in terms of just improving check-in or flow and the experience of the service. The channel, again, I think is something that we're seeing innovation around in terms of the use of mobile technologies, text messaging and so on. I think the brand is an interesting one. At Salford, we have cancer services delivered in Salford which are run by the Christie. So we have the Christie at Salford. So Christie is a specialist cancer centre in Greater Manchester. It brings a recognised brand for people in Salford, but it's local. So I think there's an interesting thing there about whether we can think about how we use NHS brand more effectively, and customer engagement. And so again, I think we start to see innovations around this in terms of peer support and sort of the way in which we have sort of engagement with patients in self-care and self-support. So having looked at all, looking at all these examples of different innovations, what I'm struck by is there's no shortage of ideas out there, but I think, there's something about thinking more broadly along the supply chain. So the Doblin model, I think, is really useful in stuff, just challenging us to think about innovating in different places, looking at the use of wider assets. And I think this whole thing from the frugal innovation of how can we make less more, I mean, that is kind of the big challenge that we have. So then moving on to to innovation as a verb, to innovate. So now this is about having a really disciplined process, and that's the thing that struck me over the last year as I've been talking to people who are sort of leading edge in innovation. And there's quite a lot of really useful materials out there to support people to do innovation in this sort of disciplined and rigorous way. So probably one of the ones that people have talked about for quite a long time is the IDEO approach to innovation. So IDEO is a design company in the US. It now actually has a not-for-profit arm that really is about teaching people in the practice of what they call human-centered design. And this is their framework, and you can find a lot more about it on their website. But it talks about these three ideas: the inspire, so sort of really understanding what's needed and the possibilities. Ideate is the next phase, which is coming up with the ideas and then implementing and trying it out. And the Design Council in the UK kind of built on, I think one of the people in the Design Council came from IDEO, and they have what they call their double diamond model, which is sort of similar. It's got 4 points. I think the thing that's interesting about this one is that they kind of have this point about problem definition, and this is something that the Design Council talk about quite a bit about, really needing to define the problem, and that often we see a kind of a manifestation of a problem, and actually, it's the root cause that maybe isn't quite as visible that we really need to go and address and innovate around. And then the sort of third thing I'd point you to is the work that Nesta do in the UK, and they have their 7 stages for innovation, which I think is interesting. It does take it further out in terms of they talk about growing and scaling and changing systems to support innovation, so it sort of takes it beyond the development of the product. And each of these organisations, as I say, have really extensive and fabulous materials that you can find, IDEO, Nesta, and then the Design Council, their bit is actually being updated at the moment, but I found that the National Institute for Health Research actually has quite an extensive description of the approaches of the double diamond method. So again, common themes on this. I think all of them embody this idea of human-centered design, which I think in healthcare is really interesting, because we often talk about patient-centered design, person-centered design. But their thing is well, this has to work for the people who are the kind of providers as well as the recipients. And I think that is so true in the healthcare context, probably more true than in many other sectors. And I think often some of the barriers that we have is that the innovations that people are coming up with are potentially great for the end user, but actually don't work so well for staff, and then that creates one of the reasons why they may not be spread and adopted as quickly. I think I was really struck by talking to people using the IDEO model about the emphasis they have on the expert skills that are needed to do this. Ethnography, to really observe people and what they're doing, why they're doing it, design skills, engineering skills. And I am struck that that's something we don't tap enough into, this expertise when we're looking at innovating in healthcare. And I think most large providers now are in cities with big universities. There's the more we can be doing to say tap into the expertise of students and training and so on. And as I said before, this kind of deep understanding of the problem, and also interestingly the emphasis on build it, the prototyping and testing. So I went to Kaiser Permanente's Innovation Centre in Oakland last year, and they just have this big space where after they've done all the inspiration and ideation, and then they do the implementation, and they actually will build things out of cardboard first of all, and then mock it up in more sophisticated, and just kind of really test things out before they get to the point of having a product. So finally then, the last area I just wanted to talk about is this idea of innovation as an adjective, to be innovative, and it's obviously a adjective that can be applied to a person, to an organisation, to a process. And I think being an innovative organisation, sometimes we tend to think about it as being an organisation where lots of people are innovating. But actually, you could be a really innovative organisation by just adopting what is out there already. And actually, the model, someone was telling me, the kind of the Microsofts and so on that we see as these highly innovative organisations, actually most of their innovations come from acquisitions of small startups, so they're kind of going out and finding the best ideas and taking them in. So there's something for me about, if we want to be an innovative organisation, how do we become better at adopting other people's ideas? And interestingly, maybe this is part of the problem, there was less really around this, but I found a couple of things that I thought were really interesting. One is a paper in implementation science on organisational readiness for change, because I guess, being innovative is about embracing change. And Weiner talks about 3 things. One is what he calls change valence, so really understanding the value of the change and to whom. And as I was saying before, I think this is often a bit of a sticking point in healthcare, because the value of the change, you know, can be very differential. For some people it might not be valuable at all, you know, because there's so many stakeholders in the health context. But so really understanding that and being clear about that. Change efficacy is the second thing he talks about. So what does the change involve? Are the resources available? And this third question, I thought this, again, really resonates for me in the healthcare sector about, does the current situation allow it? Because, again, you know, we can understand what's needed, we can resource it sometimes, but actually the reality of the day-to-day work means that things just don't get implemented. And then the third thing is kind of contextual factors, so culture, organisational flexibility, and past experience. So past experience of, you know, I mean, people still in England, you know, groan when they talk about IT because of all the difficulties with previous national programmes. So past experience, you know, things can leave a long shadow. But then trying to sort of get into understanding a little bit more about contextual factors, I came across a paper, and I don't know if you've had Paul speak on the QI Connect, but Paul Plesette, people may have come across, has done a lot of work over the years on improvement and innovation and complexity and stuff in the past in the UK. And I found this paper that he wrote in 2003, and I mean, you know, there's a link. Just go and read it, because well, you could cry or you could just say this is really useful. But one of the things that, you know, Paul talks about a lot is complex adaptive systems, and Fritjof Capra, the physicist, talks about complex systems being made up of structures, processes and patterns. And so, you know, when we talk about structures and processes in innovations, you know, we could say, you know, do we have structures and processes to spot innovations, to test them out in a small scale, and then to scale them across the innovation? But I think one of the things we're less good at talking about is the kind of the patterns, the behaviours that we need in organisations. And in the paper that Paul wrote, he talks about 5 things that shape essentially culture, or the behaviour patterns. So one is the nature of relationships in an organisation, how they're built and how they're maintained. And in the context of innovation, it struck me, this is interesting, you know, so when someone new arrives, you know, how often do we tell them, like, or ask them, you know, what are we doing here that we could be doing better? What did you do in your old workplace that we should be doing here? You know, usually we kind of, it's a bit more just forget everything you knew before, we do it differently here. So there's something about the kind of relationships and how we embrace the new and new people and learn from them. The nature of decision making, you know, do we have really bureaucratic, slow, tightly controlled decision making processes, so, you know, you just can't try anything out? Or do you have decision making that allows people to try things in a controlled and sort of safe way? How is power used? How is it acquired? Does power sit in hierarchies? Does it sit in professional groups? Is it about time served, you know, or is it about everybody having an equal voice and an equal contribution? And, you know, all these things influence the culture and I think the capacity to innovate. How conflict is managed, I mean, you know, I've seen situations, I'm sure we've all been in situations where conflict is not handled well, and then the kind of default to that is to keep things very safe, not try anything different because you don't want to rock the boat. So again, if you don't manage conflict well, that's not going to be conducive to innovation, which is going to be about sometimes, you know, people's different worldviews kind of clashing. And, you know, what do we place as importance on learning? But I think, so all of these things, it seems to me that, you know, this is a way of us thinking about where we're working at the moment, the team we work in, the organisation we work with. Do we have the relationships, decision-making, power, conflict management, and learning to support the adoption of new ideas and to be innovative? And then, I mean, just finally, I won't dwell on this, but it's a bit of an indulgence, but in Paul's paper, he makes some recommendations. And he said, a decade from now. So this is what it was going to be like in 2013. It would be commonplace that staff at all levels would think creatively, that change wouldn't be a project, it'd be a habit for change. We'd have implementation of hundreds of locally generated innovations. Innovations would be spread throughout the entire system. We'd have dedicated resources, and national and regional centres would act as a conduit to make healthcare better. And that finally, other industries would be looking to healthcare. You know, I think we've gone a really long way, but I think we probably all will recognise there's much more to do, and not least because the context that we're now working in compared to 2003 is different. So, in conclusion, there's lots of innovations, there's lots of ideas out there. There's a sense of we don't need more ideas necessarily. There's also a lot of support out there for people who do want to innovate and who have the ideas and want to think about how we do it. But what I was really struck by is that I think this question of how do we become an innovative organisation by adopting innovation is something that we seem to know less about, or to have articulated less about, in terms of the leadership and the culture that is required. So that concludes, and I think I have to give the ball back to someone. Is that right?
Yeah, that's right. Jo, thank you so much. What a wonderful journey through a whole variety of key issues on innovation. Really super. And we'll come to the questions just in a moment, but just a quick shout out. There's further information at the health.org.uk, the Health Foundation site. And also just a quick shout out to, it's great to see Jo Sherry Coutu talking with you at the Health Foundation on the 14th of March. So we'll send out a link to that as well. But let's get back now to Akin. And welcome, Akin. You've got lots of food for thought in that talk. So welcome, Akin. And perhaps you have a question for Jo.
Jo, thank you very much. That was a fantastic presentation. So my question is this, is there any correlation between innovation or creativity and joy in work? And are those organizations that are foremost known to be innovative, are they experiencing increase in joy at work? And are they becoming more productive? Are they having better outcomes? And the second part of the question will be, what can the NHS as a health system and its component organizations, what can we do in practical terms to boost our capacity for innovation and to foster that culture of being innovative? Thank you.
Yeah, thank you, Akin. Really interesting questions. And I think that first one on the correlation between innovation and creativity and joint work, I mean, I'm sure people will have written about that. I can't say I've come across something specifically on that. But I think when you asked that, what struck me was, you know, if we go back to those 5 patterns that Paul Plisek describes in his paper, you know, kind of if you think about working in an organisation where, there's good relationships, decision-making happens well, confidence, and so on. You know, that would be the sort of organisation you'd want to work in, wouldn't it? And, you know, I think, and we know those sorts of patterns are the things that are conducive to innovation. So it seems to me that, yeah, you're not really going to get innovation in an organisation where people are feeling ground down and sort of disengaged and unhappy. So yes, it just feels right that there must be some relationship between the two. I mean, I think, again, this thing of, you know, are the more innovative organisations ones that have more joint work and more productive and so on? I think it's just a really difficult question to answer in terms of sort of quantitatively, you know, evidencing something like that. But I think So, you know, I can talk about my example of being a non-executive at Salford, and I knew Salford as an organisation, you know, from its quality work before I became a non-executive there. And, you know, I'd met some of the leaders there and you could see their commitment and so on. But I think the thing that really struck me when I got to know Salford better as an organisation as a whole is that sense of individuals feeling that they can make a difference to the environment around them and that they're in that supportive context. And I think when you hear in contrast of organisations where quality of care is poor, you know, what you hear from the sort of testimony of staff who work in them is that sense of disempowerment, that they couldn't change anything, that, you know, nobody was listening. So I think, you know, it feels right that there must be some connection between joint work, innovation and kind of productivity and outcomes. But on the final point about what can we do? I mean, I think when I was putting this together, you know, I was thinking, well, you know, it's all very well me just going on about all these really interesting things I've seen, but how do you use it in the current context when we know staff in the NHS are working so hard and so stretched? And, you know, I think somehow it's how do you create that space? You know, none of this is going to happen without some it goes back to that thing about the third thing about, you know, is the environment conducive to adopting an innovation? And if people are hard-pressed, it's not going to, you know, it's not going to happen. But I do know, you know, people talk about stories of how actually sometimes just making some very small improvements start to free up time and you get that sort of snowball effect. But I think unless we can find a way of creating time and some space, it's going to be very hard.
Thank you very much.
Thank you very much for that, Joe, and thanks for the question, Akin, and just a big shout out to the innovation that you're doing in your hospital and your improvement club. So really well done for progressing that in your hospital, and thanks for joining the call today. Joe, you're welcome. Joe, the chat box is absolutely gone on fire this afternoon. Many people commenting on many of the issues that you were raising. Caroline Stephen, a QI facilitator at NHS Lothian, was concerned that sometimes people don't see themselves as being creative and hence associated with innovation. And oftentimes innovation is seen for creative people who come up with new and funky ideas and hence doesn't make itself available to the masses. Alistair Philp, who's an improvement advisor at Scottish Government, came up with a great term. I don't know if you coined it yourself, but it's fetishising novelty. And what he was going on and commenting on was your point around the implementation of existing rather than always looking for the brand new. There's a question here from Andrew Winter, who's a consultant physician in Glasgow and also an e-health lead within Glasgow. And he wonders whether attempting to plan innovation, which he's observed some of in Scotland, he wonders if that is the best way to do things, or does that risk focusing on the offering rather than other aspects that you talked of?
So I think I'm struck that I think, you know, there is a real discipline and rigour to the process of innovation. So whether, wherever, you know, if you take the Doblin 10 types of innovation, wherever you were looking at trying to innovate along that spectrum, you would need to take a planned approach to it. I think, if anything, I'd say that we probably don't stand back enough, and we tend to go down the kind of, you know, looking at for the new diagnostic technique or the kind of, you know, the sort of, you know, the new bit of kit, as it were, and we don't stand back enough and think about where is the opportunity to innovate and improve the patient experience by looking at other parts of the kind of supply chain. Does that answer the question?
Yes, it does. Yeah, thank you very much. And we've got a comment here from Marillis van Dijk from Alberta. She says that in Alberta they've focused on creating different conversations using liberating structures and using social media to communicate more publicly out of our silos. But how do we know what happens next? She goes on to talk about it's probably an art to find out where one should focus in an organisation. So I guess that goes to some of the points you were making around you need to have the culture and structures and approaches available within an organisation to be innovative. However, Karen Ritchie, our Head of Knowledge and Information here at Healthcare Improvement Scotland, has a question, which is that how do you suggest that we ensure that innovations, particularly those produced by SMEs, small and medium-sized enterprises, who are rarely able to test robustly, are more effective and cost-effective, would not waste NHS resources? So how can we be sure that what SMEs are offering us actually are cost-effective and worth trying?
Yeah, I think so. Actually, I think that's a really interesting question, and one actually, in some of the other work I'm doing around looking at how we improve health. And I think one of the things about often the offer that SMEs have is that sometimes the value of their product is more than kind of what it appears, you know. So there's things that they might have around local knowledge or sort of reach into the community, the ability to sort of mobilise people and so on, that we can't value. So I think it's a really good question, and one that I've been thinking about in another context really, which is how do you work out the value of some of the small, you know, kind of the smaller innovations and service offerings that a lot of voluntary sector organisations can have, because we've got a system at the moment, you know, that has been sort of set up and measures people on the kinds of metrics that work when you're kind of crunching through big numbers of populations or looking for sort of particular KPIs, but actually the value often of what SMEs are providing, you know, they're offering something that we don't measure at the moment. And so I think that's a real challenge as well when you're looking at an innovation of what is the value and can we really assess the value in the broadest sense, because otherwise some things might not look cost effective, but they're actually offering something more than we see on the surface.
Great, thanks for that, Jo. Some interesting comments from Andrew Barraclough from Nottingham University. Can we talk of innovative health communities and systems as well, or does it just sit at organisational levels? So picking up on some of the points that you raised earlier. One final question for today. Thanks everyone for the questions, but Mark Jennings, Director of Oxygen Consulting. Mark asks, based on your study of innovation, does competition in healthcare systems encourage or discourage innovation?
Oh gosh, that's a good question, isn't it? But I don't know, obviously, what the answer is to that. But you see, I suppose when you think about competition, I mean, actually, some of those examples of some of the innovations, when I was kind of illustrating the Doblin's 10 types of innovations, you know, actually I think what's interesting about a lot of those is it's about building the collaborations. You know, it's about bringing together a range of services in a way that is sort of more convenient for the consumer. And so I think, you know, there is something about in healthcare, you know, it's absolutely an area where we need to see collaboration to get some of the real benefits, particularly when we're talking about so many people who need care and services have multi-morbidities. So, you know, the risk of competition is that you start to compete around kind of very narrow sort of product offerings, you know, so diabetes care or COPD care, but actually we know people often, you know, need all those services, and providing them in a holistic way is valuable. So I don't know the definitive answer to that question, but I think actually if you look at what the rest of the, you know, happens around us, collaboration is something that adds a huge amount of value.
Great, Jo, thank you so much, and thanks to all the other questioners on the QI Connect today. Harry Longman, good to see you on the call. Thank you for your questions and your comments. And Tom Houston from Forth Valley also, and all the others. Joe, thank you very much. We've come to the top of the hour, folks. Just to announce that our next speaker on the 31st of March will be David Bates. David is the Medical Director of the Partners Healthcare System in Boston. He's also the Chairman of the American Medical Informatics Association, amongst other things. So we're looking forward to a wonderful talk from David then. And David fits in nicely to our now complete QI Connect 2016 Innovation and Integration series. You'll see David alongside Jeff Mulligan from Nesta, Maxine Power from Halo, Derek Feely from IHI, the wonderful Jean Nelson from the Dartmouth Institute, Steve Spear from Boston and MIT, and we've got Tim Brown from IDEO, and we've just received a word from Peter Lachman, the incoming Chief Executive of ISQA, who will join us and give a talk in November. So, wonderful array of speakers. Remember to follow us on Twitter. And just remains for me to say thank you very much to Joe Bibby today, and also for Akeen, and to the team at Healthcare Connect, whatever we're called, QI Connect at Healthcare Improvement Scotland. And we look forward to seeing you in the next seminar. Thank you very much, and goodbye.